Well, thank you all for joining this morning. I'm Jess Berry. I'm the Director of Ocular Oncology at Children's Hospital Los Angeles and the University of Southern California. And my research focus is on using the aqueous humor as a liquid biopsy. And I'm going to talk to you today about retinoblastoma and some updates and innovations over the last several years that are moving retinoblastoma towards more precise and personalized medicine. These are my financial disclosures. I do not have any interactions with any companies that sell products to patients. I do, however, have research funding as well as a provisional patent on some of my aqueous humor research, which I will discuss today. So today we're going to go over diagnosis, management of disease in retinoblastoma, which is still a hotly debated topic across multiple centers throughout the US and the world. And again, some innovations in the field, including a more focal delivery method for chemotherapy into the intravitreal space, using the OCT for retinoblastoma. OCT itself might not be super new, but its applications within ocular oncology are evolving. And then again, my work, the aqueous humor. So let's just do a brief review of retinoblastoma. As you know, it's the most common primary intraocular tumor in children. And it is, thankfully, a rare disease. There are about 250 to 300 cases in the US a year and 7,000 to 8,000 in the world. Counts for disease in about one in between 15,000 and 20,000 live births. And in general, it presents with either leukocoria or strabismus because generally one eye often sees well, the child appears to have normal visual development, and then the parents or a caregiver often notice something going on in one of the eyes. There's no male-female predilection or racial predilection. There are countries that have a higher burden of disease, and that is generally based mostly on birth rate. And in general, the average age at diagnosis is 18 months, although this, of course, is also a range from birth. And there have been rare cases of 5, 6, 7-year-olds or even adults, although, again, quite rare. And we think that's a somewhat different clinical scenario. And retinoblastoma is a genetic disease. It is, in fact, one of the main genetic diseases that ushered in the whole idea of cancer as a genetic disease and of cancer genetics. The RB1 tumor suppressor gene was the first molecularly described tumor suppressor gene, and my mentor played a huge role in that, Lynn Murphy, as well as others. And at the time that there were all of these discussions about a tumor suppressor gene, the thought was that, honestly, this was just nuts and that cancer was only an activating mutation and that there was no idea of something like a cell cycle regulator, which is what the RB1 tumor suppressor is, that if gone awry would allow a cell cycle to progress unchecked. Now, of course, we know that there are multiple tumor suppressor genes, and in fact, while the retinoblastoma tumor suppressor gene is the initiating event for retinoblastoma in the vast majority of eyes, it also plays a role in a vast majority of human cancers. Now, all children who have bilateral disease, meaning retinoblastoma in the right and the left eye, carry a germline retinoblastoma tumor suppressor gene mutation. That means that the cells in their body have this alteration and they are predisposed to retinoblastoma as well as to other cancers throughout life. But 15% of unilateral patients also carry a germline mutation. And so testing patients, but particularly testing unilateral patients, is critical for the management of this disease. Even now, even in the United States, I have patients who were told, you have unilateral disease. There's no way you can carry the germline mutation. And then, of course, they go on to have a child with retinoblastoma, or they go on to develop a second cancer, and no one can quite understand why. So if you take nothing else from this talk except for that, I think that's one of the most important and critically often missed aspects of the care of retinoblastoma patients. Now, as I mentioned, anyone who has a germline mutation can develop a tumor in the other eye, and they can also develop tumors in their body throughout life. They can pass that alteration down to future offspring, and they also, we think, have increased risk of second tumors if there's radiation. Thankfully, we don't use radiation quite as much anymore with retinoblastoma care, but it does remain a concern for some patients. And the way that we At this point in time, in the United States and around the world, still diagnosed retinoblastoma is based on clinical features. So these children have an exam under anesthesia for a clinical diagnosis of disease. And there's several features that we're looking for, including ophthalmos, as you're seeing here, neovascularization of the iris. But the more pathognomonic features are seeding, so small pieces of viable tumor that break off into the vitreous or subretinal space. Those foci can go off and develop other tumors within the eye. And then calcification. So retinoblastoma is not the only thing that causes calcification in the eye, but in a young child, if you see calcification in the setting of all these bright spots are calcification. In the setting of a dome-shaped or retinal-based lesion, absolutely retinoblastoma should be the very top of your differential. And this also varies center to center, but the two most common classifications for retinoblastoma are the International Intraocular Retinoblastoma Classification, or the IIRC. This is the ABCDE classification that is used most commonly, and many centers are either adding on or progressing to add also the AJCC, so that we, as people who take care of retinoblastoma, are talking in the same way as those who take care of other cancers, using the AJCC for staging. And as you can see, the disease progression goes from A through E, where A eyes are very small tumors and they are at restricted sites, not close to the fovea or the optic nerve. B are bigger tumors or closer tumors. C tumors have seeding, so localized seeding, either in the vitreous or the subretinal space. Group D tumors have diffuse seeding to the vitreous or subretinal space. And group E eyes are generally considered eyes that are filled with tumor, where the tumor has destroyed most of the structures responsible for vision. Again, it is arguable, but many people feel that an E eye is an unsalvageable eye and that there's some danger to the child by trying to save these eyes. Now, you'll see that the vast majority of children, even in the United States, about 80%, present with group D and E. It's quite rare to get an eye that has a smaller tumor burden. And of course, in other places, children may present far more advanced, so beyond an E, where the tumor has actually already escaped the eye and is in the orbit or extraocular space. And so currently, our prediction of which eyes will respond to therapy generally predicts about 50% success in group D and E. And again, you can see here, A, small and far, B, bigger, closer, C for seeding, D, diffuse, and E everywhere. And that's how my residents often remember the ABCDEs. Now, while we as ophthalmologists and ocular oncologists love to talk about eye and vision, the number one important thing to consider when you're taking care of a child with retinoblastoma is, of course, their life. And so thankfully in the US and Europe, we have a greater than 90% likelihood of being able to save the child's life. But as I mentioned, as children present with more progressed disease or disease that is outside of the eye in the extraocular space, that means also that their prognosis for life changes. And so retinoblastoma is really a global disease. And as a global network, it's important that we always remember that the life of the child is always more important than the limb of the child. And that is our number one goal, is to save that child's life. So let's talk about modern treatment options for retinoblastoma. Enucleation is on the top of this list, and as long as I'm invited to give these talks, will leave enucleation on this list because it is and remains an important modality for retinoblastoma, both in the primary or secondary setting. It is a life-saving surgery. Attempts to salvage the eye for retinoblastoma require one or more forms of chemoreduction, and that can be either systemic, intravenous chemotherapy, or intraarterial chemotherapy. We'll talk about both of these. Both require various forms of tumor consolidation by the ocular oncologist, and that may include laser therapy, cryo, or brachytherapy. Newly, in the last 5-6 years, many centers now give intravitreal chemotherapy, and that's meant specifically to target vitreous seeding. And then, as I mentioned, thankfully, external beam therapy is now very rarely given. Not never, but quite rare. All of this, of course, presumes intraocular disease. Once you have disease in the orbit, outside the eye itself, or in the CNS space, you're discussing a much more intensive multimodal regimen. So, enucleation, a 1 hour surgery. In unilateral cases, it's thought to be curative in 96 or greater percent of cases with a very low risk of recurrence, almost always within the first 12 months. And that likelihood of recurrence, of course, is in the orbit. These days, as our treatments have become more successful, this is often reserved for failed treatment or a secondary enucleation. And at our center, generally advanced unilateral cases, very bad group Ds. Even in D, you have a range, of course, of disease presentation. So very bad group Ds or Es, we will often offer primary enucleation to our families. And frankly, it avoids a lot of treatment and a lot of anesthesia for their children. And they're often very happy, both cosmetically and functionally, with the result after an enucleation. For salvaging treatment, again, requires one or more forms of chemotherapy. And the reason I say one or more is that very frequently you may start with one form, and due to response or due to things that happen in the other eye, you may transition to another form, at least at our site. And this is either systemic or intraarterial. Generally, alongside this treatment, you have examinations under anesthesia every 4 to 8 weeks. And as I mentioned, multiple local therapies. Retinoblastoma recurs. About 50% or more of retinoblastoma tumors will show recurrences regardless of treatment modality. And so being very vigilant for these. And the aim, of course, is to identify these recurrences when they're small and amenable to local therapy. And while there is debate in the retinoblastoma community regarding which modality is better and when to initiate them, both systemic chemotherapy and intraarterial chemotherapy have shown to be functional and to save eyes. They do have pros and cons. Each of them have pros and cons. This is an old review now, but I still sort of like the ability to just show this graph. So this is a review of outcomes by group A through E. And as you can see, again, 80% of patients do present with more advanced D and E eyes. And this is the area at which systemic chemotherapy starts to have lesser efficacy, and intraarterial chemotherapy tends to have better efficacy with more advanced eyes. Now, there are local complications of both intraarterial and systemic chemotherapy. Of course, for systemic chemotherapy, we hear a lot about the systemic complications. These children, of course, have to be monitored for neutropenia. Any neutropenic fever requires an ER visit. That being said, intraarterial chemotherapy, which uses generally different forms of chemotherapy and often is melphalan-based, can also cause neutropenia. These children still do need to have their counts monitored very closely. And there's also some local complications, which are all vascular, right? Intraarterial chemotherapy is an endovascular procedure where you're delivering that chemotherapy through the ophthalmic artery into the eye. And so you can see some transient things like periorbital edema, skin erythema, or nasal lash loss. There are some procedural complications. Some of these children can develop bradycardia that the anesthesiologists need to be prepared for and ready to manage. And then more rare, thankfully, complications such as an avascular retinopathy or a sectoral, basically a stroke in the eye, choroidal or retinal occlusions. Metastatic disease and the risk of metastatic disease after any therapy is still an issue that we as a community are grappling with, and how to avoid that, because again, our number one goal is life of the child, specifically over trying to save an eye that may have very little visual function. All of these modalities will require consolidation. And so this is here me giving laser to a child. This photo, of course, reproduced with parental permission. And you can see this is from one of Dr. Lynn Murphy's publications, just showing this is a RB1 mutated child. You can tell that by all of the separate tumors that are coming up. And this child just had multiple sessions of laser to control each of those small tumors. So what is the increased risk of metastatic disease when we think about treating a child that has advanced retinoblastoma? And does the mode of treatment matter? So Yusuf et al. Looked and found overall a 2.1% rate of metastatic disease for patients who had been treated for retinoblastoma. And then Other reviews suggested that it's possibly higher in children who were having treatment with intraarterial chemotherapy in the range of possibly 4, 5, or 6% of these children. That being said, we also looked at the risk of metastasis and orbital recurrence in children that were treated with systemic chemoreduction, and we found that the rate was less than 1%, but still not zero. And it was similar overall to patients who had been treated with enucleation. So even after enucleation, the risk of metastatic disease is never zero. That being said, I think as a community, our goal should be zero. And so while we might not attain that goal, it's very clear that if retinoblastoma is removed from the child before it spreads, we can save the child's life. Now, knowing exactly when to remove that eye or getting the child into our care when we're still able to do that, that's a work in progress and it's a moving target. But at least for me, as someone who takes care of children with retinoblastoma, that's our goal, 0%. So because of that, and with a goal in mind, then you need to start thinking about what is the treatment goals versus the risk to these children. And this is especially relevant with new treatment modalities and an emphasis on globe salvage. And I'll show you some examples. So what is the risk to the child of treating an eye like this that is full of tumor? You can see there's neovascularization of the iris. I'll tell you that the pressure is over 40. Is this an eye that we should treat or an eye that we should remove? Well, part of the complicating issue with retinoblastoma is all of us who've treated this disease have eyes like this, an eye that's filled with tumor and responded very nicely to treatment. And the child is now 2025, has good visual function and is alive and well, even though at diagnosis, there was quite a burden of tumor. And so how do we identify which eyes may do better and which eyes may actually have some functional vision? Not only just at diagnosis, but we also have to think about recurrence. So this is a child, a familial case, came in very early to us, was diagnosed with a group B, did very well with treatment, although you can see there's some waxy changes down here. It's definitely an area that you would need to watch. And very quickly, there was an aggressive recurrence about 6 weeks later. This is a fair amount of tumor growth within a 6-week period. You can also have a recurrence in the setting of vitreous seeding. Thankfully, we have a much better treatment for this than we did even when I was in training. But this is a child, you can see, nice calcified tumor. Obviously, there was a good treatment effect here, but at some point started to develop a mass. And because there's not the same retinal architecture here on these calcified tumors, these seed very quickly. And so you can just see it. I mean, look, this eye is filled with several active vitreous seeds, all of which can lay down on the retina and develop new tumors. But outside of even intraocular recurrences, there's extraocular recurrences. So this is a child that had an intraocular recurrence and was undergoing laser therapy and subsequently developed an orbital tumor. Now, we don't know for sure, although we published on this, that maybe you can see there's some thinning of the sclera here. Maybe the tumor growth itself combined with the aggressive laser therapy helped thin the sclera and this tumor escaped into the orbital space. And you can see that mass right there. And this was a scary case for me. So this is another patient who, again, had a nice treatment effect and then developed a pretty large recurrence. Obviously, this is in the macula, so the central visual function was not very good. You can see there's actually a clear space clinically between this tumor and the optic nerve. And so the decision was made to stop treatment at this time and to perform an enucleation. And even though there was this clear space, there is actually invasion of the optic nerve here. And you can see retinoblastoma outside the nerve, which of course changes the treatment protocols as well for these children. So while this may be our desire, and it's definitely my desire for every single child with retinoblastoma, the reality is that sometimes these tumors are too advanced. And it's important as a community that we balance all innovation with safety of the child and the reality of this disease. So I'm going to move now to talking about some of our innovations, again, over the past 5 or so years, and I'm going to start with treatment for seeding. So seeding in the vitreous and or subretinal space, but really the vitreous space previously was Very, very difficult to treat. It was the number one cause of secondary enucleation after failed attempts to save an eye. And you would just get to the point where you were chasing yourself because you'd have all these seeds in the vitreous and they were falling down and making all of these tumors in the retina. And there just wasn't really a good way to get ahead of the cancer. At that time, the main treatment for vitreous seeding was external beam radiation. Now, retinoblastoma is generally very radiosensitive, and so you could give a curative dose to the eye at a dose that's relatively well tolerated to the eye. However, the concern that we have with radiation is, of course, the side effects of cataract in a young child, where we're trying to save vision in a time where cataract surgery was not routinely done in retinoblastoma patients. And then, of course, in second cancers. Because of the second cancer risk, it's almost completely contraindicated in children under 12 months of age. And even in older children, there is a risk that this can be a site of second tumors in the future. And frankly, they're thought to be worse than the retinoblastoma itself. And so, a little over 10 years ago, Francis Munier, who's a Swiss ophthalmologist, introduced a safety enhanced approach to intravitreal chemotherapy in retinoblastoma. And this is an example of that being done. So, one of the first safety enhanced approaches was to take the aqueous out of the eye to lower the intraocular space. You had already done a UBM to ensure that there was no ciliary body invasion in this area. And then you can see, I'll play that one more time if I can get to it. Here we go. You can see also that you cryo at the injection site so that as you're withdrawing the needle with the chemotherapy, if any active seeds are coming with you, you would kill that with the cryotherapy. Now, Dr. Munier was not the first to suggest injections into the eye. And in fact, others had done so, but often there were complications. So this safety enhanced approach allowed us for the first time to be able to give chemotherapy into the intraocular space directly. And of course, as ophthalmologists, we're very used to giving intravitreal therapy for far many other reasons. However, as you can imagine, all treatments have complications. And so let's talk a little bit about the goals of this therapy. So the intravitreal injection, of course, is meant to go in to target these seeds. The blue here is the vitreous, the red is the retina, and the yellow, of course, is the tumor. And you can see this is part of our technique here. You're doing the paracentesis, you're marking the site. When you inject, the needle is visualized behind the lens and you see the cryo. And the goal is pretty impressive removal of all visible vitreous seeds. These either go to invisible or calcified, and it's a pretty impressive thing. So these eyes don't even look the same, but this is a patient who had a recurrence and had this baseball of seeds, and you can see they all go away. You see a little bit of this salt and pepper retinopathy off in the periphery. That's also quite common. And this is a home run success for this eye. Unfortunately, we found that in some patients at some times, generally after the first injection, they developed a toxic hemorrhagic retinopathy. And these are two such cases where it almost looks like a combined CRAO, CRVO in the eye, blood and thunder everywhere, retinal edema. And so we still don't actually know what is causing this, whether it has to do with the dose of the melphalan or whether specifics about the patient population. I encourage anyone to continue to study this. Several centers have. We proposed our hypothesis that as we showed, there's the retina and the vitreous, the tumor, the chemo going into the eye. And after the first injection, we know from adult studies that oftentimes there's a vitreous detachment. And so what we hypothesized is that potentially after the first injection, you then inadvertently inject the medication into a tighter volume under that vitreous space, thus concentrating the chemotherapy against the retina and causing basically a retinal necrosis. And the aquaplasmin study in adults showing the increased risk of PVD supported that. And our review also of our patients, both at the time of injection, where there was not a visible PVD, versus after, where there was in these two patients, suggested to us that maybe this played a role. Here's an example of how dramatic the toxicity is in these patients. So this is a nice intact fovea. This child had a nasal tumor. And unfortunately, after the toxicity to the intravitreal melphalan, you can see the significant retinal atrophy there. That being said, we evaluated this in a retrospective fashion, and we actually did not find a link to vitreous detachment and this toxicity. And so we as a community are still trying to better understand and predict which children may respond very well. That's our goal, or have this toxicity to this disease. Let's not now talk about OCT for retinoblastoma. So you saw this eye before. This was a very advanced eye. Again, neovascular glaucoma, pressure of 40 at diagnosis. Other eye looked pretty good. So we went forward with a primary nucleation. Blood was sent for RB1 testing, and then the patient came back. I always test my residents and tell them that if I'm going to show them this picture, there's a reason for it, and to see how many tumors they can pick up and where they are. So I'll have you test yourself there. But I'll tell you, when we looked in, looked pretty good. We got an OCT, and here's what the OCT showed. There's tumor 1, tumor 2, and tumor 3. I'll play that one more time. I know it goes fast. Right above the optic nerve, here we go, tumor 1, tumor 2, and tumor 3. So there are, in fact, 3 small tumors in this eye that are so small to almost be invisible to the naked eye. They're barely distorting the retinal architecture, and so that makes them not so visible to the human eye clinically. But you can detect them on OCT, and we were able to give just focal laser therapy for those 3 small tumors, and that patient did very well. You can also use the OCT to monitor for scar recurrence. So this is a patient that overall looked pretty good. You can see a little bit of thickening here at the top of the tumor, but was responding really well to the therapy. You see this heterogeneous mass here, although 1 week later, you can see that there's an alteration there, and this is becoming less heterogeneous, more homogeneous, and more nodular, consistent with an area of recurrence. You can also use the OCT to both detect and to monitor seeding. And I love this picture. This is a nice vitreous spherical seed here. So spheres are a type of a vitreous seed, and these can be more resistant to therapy because the sphere itself is encapsulated, so a little less sensitive to the chemotherapy, and it continues to let seeds off, dust-type seeds off into the vitreous space. And finally, I'm going to end with a discussion about my work, which is liquid biopsy for retinoblastoma. And so, as I've mentioned all along in this talk, retinoblastoma is diagnosed clinically, recurrences are diagnosed clinically, and we monitor these eyes clinically. This is not a tumor that is routinely biopsied, and that's due to concern for tumor spread. Again, not a hypothetical concern, but a real concern based on inadvertent attempts in children where they either thought it could be done safely or where they didn't realize there was retinoblastoma and it caused tumor spread. And while ocular oncologists are overall quite skilled at looking at the eye and identifying retinoblastoma, a lack of biopsy actually has impact, right? This is why we biopsy other solid tumors, including all pediatric solid tumors and even other ocular tumors, because biopsy can be helpful. So in retinoblastoma, our lack of biopsy means that we have a lack of eye-specific diagnostic and prognostic markers for this cancer. Because we don't have those markers, we have a lack of personalized treatment plans. Our treatment plans are based basically on the age of the patient, the group of disease, and the laterality of the disease. And we have some limited understandings of in vivo tumorigenesis for retinoblastoma. So we know a lot about how tumors are formed from tumor specimens and eyes that have been enucleated, but how tumors are responding to treatment at a molecular level and what happens at the time of recurrence is not well understood. And so we've already gone over this, but intravitreal chemotherapy injections started in 2012. There was a lot of anxiety as it related to starting to put a needle into an eye with active retinoblastoma, even with the safety enhanced mechanisms. But it's been well studied. And in this pretty large review done now back in 2017, there were no documented cases of extraocular spread using a safety enhanced approach. And so this really led for us to a new opportunity. For the first time, we were putting needles in eyes with retinoblastoma, and we were extracting aqueous humor from those eyes at that time. Initially, we were looking for cells in the eyes or after just throwing the aqueous away until we had the idea like, hey, maybe there's something in there. Since we're already taking the aqueous, maybe we can study this to see whether or not it may overcome our lack of tumor tissue in these eyes. So liquid biopsy is a term that's really thrown around a lot, both in the scientific, but also the public media. And so what really is a liquid biopsy? So a liquid biopsy is a biospecimen that is a mix of cellular or non-cellular components that are derived from the tumor. And from those components, you can identify specific things like cells, proteins, nucleotides, various things. DNA, which is what I'm going to focus the majority of the rest of my talk on, is the main one. And most people talk about blood as a liquid biopsy. So blood is a liquid biopsy for any cancer in the body, right? The idea that it's shedding into the blood. But there are also proximal liquid biopsies like CSF for CNS tumors, saliva or pleural effusions for head and neck and respiratory tumors. Urine has actually gained hold as a liquid biopsy. I joke all the time that they need to update this slide now to include the aqueous humor for the eye. And so while a tumor biopsy is one little piece of this large tumor, it gives you a snapshot. You can see pieces of it, but you might not really see what the whole picture is, right? A liquid biopsy gives you the whole picture of all of the molecules from the tumor that are shedding into that biospecimen. And importantly, liquid biopsies are repeatable. So longitudinal liquid biopsy can be done over time, and you can see how that tumor is changing under therapeutic pressure at the time of recurrence, and even what might be driving those changes. And so liquid biopsies, at least as it relates to DNA, generally are looking for DNA in one or two mechanisms. And I'm just going to touch on it briefly so that we all know the lingo as I move forward through some of our slides. So whole genome sequencing means that, again, you're looking at all the chromosomes on the genome. Generally, you're looking at low pass whole genome sequencing, which means you're not sequencing the whole genome, but like 0.1 or 0.3 of it. And then because we have a reference genome now, you know the sequences. And so you can, what we call bin them, you can put the DNA that was sequenced in those bins. You can count those reads. And you can identify if there are too many or too few copies of chromosomes in those regions. And we know that these alterations, which are called somatic copy number alterations or SCNAs, is a biologic mechanism that cancers co-opt in order to grow. And so this aneuploidy, or again, these chromosomal alterations can identify tumor DNA. You can, of course, also look for specific genetic alterations, and you can look at a variety of cancer genes. Even from one sample, you can look at more than one. But for retinoblastoma, of course, targeted sequencing makes sense for the retinoblastoma tumor suppressor gene. Here, you need to do really deep sequencing. So we're not talking 0.1, 0.3. We're talking like 500 times sequencing in that gene region. But to do that, you can get down to a very low tumor fraction. You can detect these alterations down to about 0.1. And again, in this case, you're looking for SNVs or single nucleotide variants or alterations in that gene. So I try to explain this clinically as these are two ways to detect tumor DNA in the same way that we have two ways to detect retinoblastoma. We do an EUA, we look at how the whole eye has been altered and what compartments in the eye are affected by retinoblastoma. But then we also combine that with MRI imaging to look at the optic nerve or the CNS areas outside the eye that we cannot see. And so for us at Children's Hospital Los Angeles, we developed a profiling workflow whereby we took the aqueous humor. Initially, it was only at the time of intravitreal injection, although that has changed. We were able to identify cell-free DNA in the sample and then do low-pass whole genome sequencing to identify these chromosomal alterations. And so here's an example of a normal cell. This is a non-cancer cell. This is an example of a cancer cell that has this altered genome with this altered genomic profile. You can see areas of too many or too few copies. And so from this, we were able to answer some really important questions as it relates to liquid biopsy. The first is quite simple. Is there tumor DNA in the aqueous humor? And the answer is yes. And so we and others showed we were the first, but others followed suit, which is great to show as proof of principle that you can detect tumor DNA in the aqueous humor. There was lots of press around this initial discovery. And so this was an example of 3 eyes. 2 underwent primary enucleation. And so tumor is shown in red. The alterations in the aqueous are shown in blue. And then case 3 was really the cincher for us. This was an eye where we were attempting salvage. We were taking the aqueous humor at each injection. And you can see here, just look at the shape, that this is a relatively complex profile of gains and losses, but that shape is stable over time. So something is contributing that DNA. Of course, it's the tumor in the eye. You're getting this stable profile over time. Unfortunately, this child did not respond well to treatment, so enucleation was done. And it then allowed us to show that, again, that profile we had been detecting all along was, in fact, the same profile that's at the level of the tumor. And in fact, we were also able to show that this is consistent with a signature for retinoblastoma. So this signature had previously been shown from tumor from enucleated eyes, and this is nice work from Ursin Coy showing areas of common gains and areas of common losses in retinoblastoma. And again, just pay attention to the shape. You can see that we were showing similar areas of gains and losses in our work. And so with that work, we started to move forward into making this more applicable for testing, discussing how we could use this more frequently in children with retinoblastoma, and to really study what kinds of information you could find from these samples to move it towards the clinical space. And what we found is that less than 5% of aqueous humor samples are removed for quality control. Greater than 95% of samples at all times have some DNA at a level that's detectable and can be analyzed. And at diagnosis, 98% proven DNA. Now, if you take out group A eyes, which are the tiniest eyes, and you include only tumors that are 3 millimeters or larger, we actually found that 100% of eyes at diagnosis have tumor DNA that's detectable in the aqueous humor. So the smaller volume eyes might not, but group B is a 3 millimeter eye. That's still a pretty small eye. And here's some examples of this diagnostic aqueous humor. Again, as we moved to the clinical space, we started taking aqueous humor at diagnosis. And you can see these are the kinds of alterations you might see in aqueous humor from retinoblastoma, and also that they are different, right? So you're not getting the exact same molecular profile each time. That's important. That tells us that these molecular alterations are, in all likelihood, just like other cancers, driving these tumor behavior and tumor activity. And so our understanding of them, as it grows, we may be able to more clearly personalize medicine for these patients. Now, these patients also underwent RB1 testing, and if we were able to identify them, they were here. This is a report after our first year of doing this with the diagnostic aqueous humor, and very soon we have had a 5-year report released, and very soon we'll have an update to that report. So I've already given you the answer to this, but can the aqueous humor play a role in diagnosis? Of course, the answer is yes. So not only is the DNA detectable, but it can be used as a companion diagnostic, both through the alterations, but also a more specific alteration, of course, those RB1 mutations. Now you can detect these RB1 mutations in the aqueous humor and then specifically test for them in the blood. That makes your test for germline RB1 alterations more sensitive because you know the alterations in the tumor. The aqueous also has high enough fidelity that you can identify if there are 2 RB1 mutations that are driving tumorigenesis, or something called loss of heterozygosity, which is a common mechanism whereby you get this loss of the functional RB protein. There are lots of other clinical questions that this can help us with. So we, again, as a community, are pretty good at identifying retinoblastoma and retinoblastoma recurrences when we can see into the eye. But when we cannot see into the eye, this is more difficult. So whether it's from cataract or for hemorrhage, it can be quite difficult. And in all of our hands, there have been eyes that have presented somewhat in an atypical fashion. Maybe there's blood, no history of trauma. There's mass in the eye with a little bit of calcification, but not a ton. And so in the past, some of these eyes have come to enucleation simply to be safe and to make sure that there wasn't retinoblastoma lurking inside. But now I think we have a test that can help us. Can the aqueous humor play a role in prognosis for us understanding which eyes may be more likely to respond to therapy and more likely to be saved? Answer again here is yes. And this really came from the operating room for me. As a surgeon who takes care of retinoblastoma, I thought it was so frustrating that two kids would come in and look exactly alike. They would have the same burden of disease, and we would give them the same treatment. One child would do really well. This tumor, almost after one cycle, would calcify and look amazing. The other child would have persistent and recurrent disease again and again until ultimately would do a secondary enucleation. And I wanted to know if we could identify these earlier and either augment therapy so that there was more aggressive therapy for the more aggressive phenotype, or to choose an upfront enucleation. And so we were able to, in one of our very early papers, for the very first time, compare DNA from eyes that were saved and tumor DNA from eyes that were enucleated. Now, of course, the reason this had never been done before is that prior to using the aqueous humor as a liquid biopsy, you only had DNA once the eye was enucleated and you could access the tumor. But with the ability to compare these two groups, the red are the eyes that were enucleated and the blue are the eyes that were saved, very quickly we were able to identify that there's a difference here. And this is chromosome 6p, which tends to be gained as a whole P-arm gain in retinoblastoma. And we found that gain of chromosome 6p was not only more common in eyes that were enucleated, but the amplitude, the number of copies of the 6p gain were higher in these eyes. You can see here with the blue. Not that it's not present, but the number of copies, you might have one extra copy, or with a mosaic or clones within the tumor, I should say, not mosaicism, but different clones. Let's say you get one extra copy or less, but in these eyes that did poorly, you're talking 2, 3, 4 extra copies. And so does that matter in terms of our ability to save the eye? Well, at our 2-year outcome, we showed that the likelihood of saving the eye was far higher if 6p gain was not present. So these were the eyes that in our hands tended to do well versus eyes with 6p gain that did not. Now, it doesn't mean that we never saved a 6p eye or that we only lost eyes that had 6p, but rather that there was quite a clear difference in the prognosis of these two groups. And in fact, if 6p gain was present, it was associated with a 10 times increased odds of that eye failing treatment and needing enucleation. Can the aqueous play a role for monitoring therapeutic response within the eye? Again, we found that the answer is yes. And I love this. People who've come to my talks, you've seen me present this case before, but I really like this case. So this is a patient that has an active disease here, an active seeding. So your retinal tumor and active seeding. We're treating with injections as well as laser therapy, and you can see a very altered chromosomal profile. So again, you take nothing else. This is your second take-home point from this talk. You see a profile like this, cancer is active. There's cancer DNA here. So you have a very altered profile. But as we continued the injections, the profile starts to normalize, and this is tumor fraction. The tumor fraction, or the percent of tumor DNA in the aqueous humor, starts to plummet. Clinically, the eye starts to do better. Everything is looking good. At injections 4 and 5, clinically, the child looked quite good. Although if you look, the tumor fraction is starting to go up slightly, and you're starting to see some of these alterations pop back up. And in fact, at visit 6, you can see here again now a large recurrent retinal-based tumor and a very highly altered genomic profile. So at 4 and 5, at this point, it wasn't even just me. There were 2 ocular oncologists. We both looked in this eye. We both thought the eye looked stable and that the eye was responding to treatment. But at a molecular level, the aqueous humor had information that we as clinicians just looking in the eye did not, and it was portending relapse. You can see that right there. Now, does blood play a role as a liquid biopsy? Absolutely. There's been a lot of good work on this. This is a really nice review from Amy Garish, and she put together this review talking about liquid biopsy in general with a focus on aqueous, but also blood. Our colleagues at Sloan Kettering Cancer Center and Curie have really been leaders in the space as it relates to blood. Now, blood-based sequencing, again, in this case, you're really looking for a needle in a haystack. So the whole genome sequencing, this low pass whole genome sequencing, is not very functional in that setting. But instead, you can do very deep targeted sequencing. And what's been found and presented so far is that in advanced eyes, there can be some detection of mutated tumor-derived RB1 in the blood. You can detect that. And that detection plummets after treatment. Now, whether that's enucleation or whether that's one cycle of, in this case, intraarterial chemotherapy, after that, you can generally no longer detect it. If you can, it often means that that child is at risk for development of metastatic disease. So a persistently elevated signal in the blood should suggest that there may be something going on at the level of the body. The question always posed to me, which is good, is can't you just use the blood? Can we not put a needle, even a small needle the size of a human hair, into a child's eye? Can we just use the blood? And so far, my answer to this is no, and there's two reasons for that. The first is that we did a head-to-head comparison of aqueous humor and blood in 20 patients, and we found that only the aqueous humor had high enough tumor fraction for this low-pass whole genome sequencing, again, to see these chromosomal alterations. So while you may be able to detect that there is tumor DNA in the blood from detection of an RB1 alteration, if you want to look at these more prognostic and cancer-driving chromosomal alterations, you need a proximal liquid biopsy for that. And so in this case, it would be the aqueous. And furthermore, nearly 40% of children have disease in both eyes. And so here is one of, we now have many examples of where a child has a right and a left eye involved with retinoblastoma, and the alterations that you see in those eyes are different. This likely is why these patients have a different response overall to therapy, and you cannot find these in the blood. Are there other eye-specific biomarkers in the aqueous that might teach us more about cancer? The answer here is also yes. So aside from DNA, of course, there's RNA, there's other molecules that can be identified. And one that my partner in the lab, Dr. Leah Xu, is really excited about and really working on is these extracellular vesicles. So this is just aqueous humor unprocessed, and you see all these vesicles floating around. It's very interesting. You can find these even in pediatric cataract and glaucoma eyes, although the kinds and types of vesicles we see in cancer eyes appear to be different, and likely these vesicles are also playing a role. You can see here about the size and quantity of these vesicles, and you use antigen profiling to identify sort of what kind of vesicles are present. And again, we found that there was a difference in patients with retinoblastoma. We also found that CD63 vesicles seem to be very predominant in the eye, although they are not present in many other body fluids. So it's likely a eye-specific population of vesicles. So I believe that analysis of cell-free DNA in the aqueous as well as the blood will really be the basis of the future of RB, and I hope that it will let us catch up in all of the ways in which personalized medicine have benefited other children with solid tumors, where you identify an actionable alteration and you change the way you treat the child based on that. Here's just an example of the future of RB care with the aqueous humor. So you can see here, this child had a large group D tumor, and at diagnosis, this is presenting a little funny, sorry. At diagnosis, there's 6P gain here, which is quite large. And this 6P gain persisted. This is a child that did not respond very well to therapy. They were treated with intraarterial and then intravitreal, and they required a secondary enucleation. Versus this child, here's the diagnostic aqueous humor here. Very small level of 6P gain does not meet our threshold to call it as a poor prognostic biomarker. This child was treated with systemic chemotherapy and also intravitreal melphalan, responded very well to treatment, and this eye was saved. So we now have a clinically available laboratory test at CHLA, and we get samples from around the country and the world, both for research, but also to answer some clinical questions as it relates to retinoblastoma. And our ultimate goal, of course, is to improve patient outcomes through discoveries in cancer care. And I think we've shown that this goal is in full effect, and we're making progress here for these children. I don't do any of this work alone. I have a huge aqueous humor biopsy team and a clinical team that helps me do this research work as well as the clinical work. And so I'm speaking on behalf of all of them today. as well as CHLA and USC, our institutions who've been super supportive of this. Here are my resources, which I'm happy to share with anyone, and thank you so much. So let's see, the first question that I see is, now we need to do diagnosis between retinoblastoma and Coats disease. Yes, we've done that and we've published on that. If you want to email me, I can shoot that over to you. And again, our newer publication using the clinical test is able to show that for retinoblastoma and Coats disease, we are able at a molecular level to distinguish them. So no patient who had Coats or fever or any simulating lesion had any DNA in the aqueous humor. And again, at diagnosis, large retinoblastoma tumors, 100% had DNA. So we have very high fidelity for helping diagnose Coats. This helps a lot, honestly, for my retina surgeons, because if I want them to go into a Coats eye and drain it, they really want to know that this is not, in fact, a retinoblastoma eye. So it's been very effective here. Let's see, the next question. In Vietnam, ophthalmologists, may still not be able to identify the difference between retinoblastoma and Coats disease. That's not true just in Vietnam. That's true around the country and the world. We've had times where, there's now one ocular oncologist, but we used to have two at our center, and we have two pediatric retina surgeons. And we've had cases before the aqueous was in use where we couldn't surely tell. We just were not entirely sure. It can be difficult in some cases. Someone asked, what type of cells do you have in a retinoma? So if by retinoma you mean a benign retinoblastoma, we have also looked at that. In a benign tumor, you will not see these alterations. So retinomas are not yet cancer. They will not show the same alterations. And then also, just to be clear, we're not identifying cells in the aqueous humor. We're identifying cell-free DNA that we can sequence to see those alterations. So how can we make the risk zero? That's a great question. You could come to the International Society of Ocular Oncology and we could debate this forever. I think the way we make the risk zero is twofold. One, we need to get these kids into us earlier. So again, even in the US and Europe, we're seeing advanced disease in the intraocular space. In other places, these kids aren't coming in until it's already too late. That's one. These kids need to come in earlier. And that involves public health, education campaigns, targeting parents, because it's parents and caregivers who detect retinoblastoma. That's one. Number two is we need to, as a community, decide that if we treat an eye and then that child develops metastatic disease, that was a failure on us. We need to be honest about it. And I think we need to say our goal is zero. And we're all going to learn together and do better to not treat eyes that are potentially dangerous and have the potential of developing metastatic disease. I'm not sure we'll get to zero. We probably won't. But I think if our horizon is zero, and if that's our goal, the patients with retinoblastoma will only benefit from that. Which intravitreal chemotherapy is used? So melphalan is our gold standard chemotherapy. That's what's used for most patients, although melphalan is the one that had the toxicity that I showed you, and melphalan toxicity is now pretty well described across multiple centers. So in some patients that are, let's say, monocular or that had signs of toxicity, topotecan may be used instead. Topotecan is thought to be a little more gentle, but conversely, a little bit less effective to the eye. Some people have hypothesized that a darkly colored fundus may have a higher risk of melphalan toxicity, but the exact eyes that are going to have it just have not been well delineated. I've not used carboplatin, although it has been described, but melphalan and topotecan have far more data, far more data. And is it possible to combine the intravitreal chemotherapy and the intravenous chemotherapy? So yes, absolutely. That's the basis of the current COG trial that's active in the United States. You start the child on systemic chemotherapy, and then generally after cycle 2, you start to inject in the eye so that you have two mechanisms of treating these tumors and to decrease the tumor burden. I'm not the PI for this study, although CHLA is the leading center. I will tell you that even outside of this study, we use that approach to therapy, particularly in children who have bilateral disease. So the systemic chemotherapy goes through their body, treats both of the disease, and then we can augment that therapy with intravitreal, and we've had very good success with that. Are children born prematurely more at risk for retinoblastoma? No, although it can be more difficult to treat the retinoblastoma in those children. Of course, they're far less likely to have intraarterial. We talk about intraarterial as this wonderful success in the treatment of retinoblastoma, and it is, but there are some procedural considerations in play for intraarterial in a way that they're not quite so much for systemic, and a very small premature child is one of those. Children who are premature are often undergoing ROP exams. So the premature patients I've had, they're actually detected quite early. When administering intravitreal medication in infants, how far behind the limbus do you go, considering that the pars plana is smaller than adults? So if you read the paper by Francis Munier, he talks about that from a technical standpoint, but most people go around 3. Now, of course, if you had a premature child, or if you were injecting at a very, very small age, you might want to lower that in the same way that like ROP babies who get Avastin, they're more at like 2.5, but in general, around 3. Which imaging is preferable for the diagnosis of retinoblastoma? And in general, MRI is preferable, and that's because, again, many of these children have a heritable RB1 mutation in their body, and so we like to avoid radiation in these cases, and CT, of course, does have some radiation in it. That being said, if CT is the only modality that's available, or sometimes we just don't know entirely what diagnosis we're looking for, and we need to identify calcification, so CT is sometimes used, but the preferable is MRI. Would it be appropriate to liquid biopsy the fellow eye at all? That's a great question. So right now, we only biopsy eyes that we see something in. So if we see like Coates or PFE or a pseudoretinoblastoma and we want to rule out retinoblastoma, we would biopsy that eye. If retinoblastoma is in 2 eyes, of course, we would biopsy both of the eyes. But in a completely normal eye, we would expect a completely normal test. We don't think that it is going to help us diagnose or prognosticate anything. So right now, there's no role to do that in the fellow eye. If there's another follow-up question to that, please shoot it in there. Yeah, so this is a great question. This is from Maria, Colorado. Do you follow patients with 6P gain more closely, and is your initial treatment approach different in these patients? So right now, our initial treatment approach is not different. That being said, this is an active area of research, both for my lab as well as for my clinical team, in order to use biomarkers to guide care for these patients. We do follow these patients quite closely. We just recently actually had a patient who, this was before our use of the aqueous humor clinically, when it was still only in a research sphere, have a late recurrence of retinoblastoma with 6P, high-level 6P gain. And had we been in a setting where we had the clinical test, we absolutely would have followed this child longer in the OR, right? You see these kids under EUA have you can just see the eye so much better. So we don't move these patients to the clinic quite as quickly. If the cancer reaches the brain, what will we do for the child? So again, that the COG studied that. It's multimodal high-dose chemotherapy that requires a bone marrow transplant followed by radiation therapy. And for non-CNS disease, it works pretty well. For CNS disease, we still struggle in that area, but that's a whole area of neuro-oncology. But the COG trial is the best basis for information there. Another question is there any role of LDH in the AH, especially in countries where DNA biopsy is not available? So, there has been some really nice work. In fact, Lynn Murphy did some initial work way back on LDH in the aqueous humor in eyes that had been enucleated, and the LDH levels are definitely higher. And it's so non-specific that in our hands, that's not been something that we have done, but I guess it is possible in lower resource settings. If you don't have the ability to sequence the DNA, that's something you could probably look at. That being said, it didn't have quite the sensitivity and specificity of the DNA. And so I think there'd have to be larger studies in doing it now, not in enucleated eyes, to be able to answer that question. So good idea. It's not a question I'm fully able to answer with our research. What is the likelihood of a child developing retinoblastoma in the second eye? So asynchronous retinoblastoma, so meaning you detect it in one eye, might find out the child has an RB1 mutation while you're monitoring, and then they develop tumors in the other eye. That's been reported to be in about 4% of cases. Another question is there a role for 23 or 25 gauge vitrectomy in cases with SEED followed by intravitreal melphalan? So most of the vitrectomy work, which is being called tylectomy, Tylectomy, was done in China. And at this time, it's not something that's being done routinely in the United States, and so I can't comment on that. We do, however, have vitrectomy later in eyes that might have a retinal detachment from therapy, and we use the aqueous to make sure that the eye is not active before our retina surgeons go in. But again, there have been a case series based in China looking at vitrectomy and tylectomy. Would it be more practical and economical on the part of the family to have the eye enucleated, especially in developing and low-income family? I mean, sure, there's been a lot of global work done on that, and this is why I say enucleation is a life-saving surgery. It absolutely is. And for a child with unilateral disease to have one surgery and then be able to go home and be with their families and be cured greater than 95% of the time, absolutely. Now, of course, not all children have unilateral retinoblastoma. 40% of them have bilateral, and you may be in a situation where you're trying to save any eye and any functional vision. I'll have the team make sure that they send out my contact, although given the number of emails I get, I think if you Google me, you probably will find my email pretty easily. So another question said, I sent one sample for cfDNA analysis and it didn't show anything. Does it mean it's not diagnostic? So no. So when it says there are no alterations present and there's no ctDNA identified, that means that there's no tumor activity in that eye. So it depends on the time you sent it. So if you sent it at diagnosis and you knew that there was an active tumor in the eye, I would say that would be a false negative test. Now, at our institution, we've had almost none of those. And so if you did it at at the end of therapy in an eye that had been treated and you were looking to see if there was still tumor DNA, but the eye looks stable, that's exactly the answer you'd want to receive. I hope I'm being clear there. So tumor DNA is present in the aqueous when active tumor is present in the eye. If you took an eye with retinoblastoma 20 years later and you took aqueous DNA, it would be a normal profile because there's no active tumor to shed DNA into the aqueous humor. So at the end of therapy, that can be a very effective time to look at the profile because you're at the end of therapy, the eye looks stable, but like the case we show, you want to make sure that there's not recurrent disease lurking. A negative profile can be very helpful there. And it will say no ctDNA or circulating tumor DNA identified in the sample, at least at our institution. So I can share a video of aqueous humor biopsy, but it's basically the beginning of the video that I showed. So it's just a very simple paracentesis. If you search my name in our laboratory, we actually have a video online that you'll be able to see. In your experience, have there been cases where post-enucleation, the histological diagnosis turns out to not be retinoblastoma? So thankfully, in my own hands, the answer here is no, although I was trained by Dr. Lynn Murphy, one of the absolute godfathers of retinoblastoma, and he shared with me that several times that had happened. We once, in a sort of atypical scenario, told the family that this eye should come out because it had been very damaged. It was a Tisical eye. We wanted to make sure it wasn't retinoblastoma. And of course it wasn't. It was lower on our differential, but it wasn't zero. So yes, I would say anyone who treats enough retinoblastoma will see a Tisical eye with calcification on the inside, and they're going to take the eye out to make sure it's not RB. If there are anterior chamber seeds, is it a contraindication to performing a biopsy? Yes. And so again, if you look up a great paper is the Jove paper on paracentesis procedure, all available on PubMed, has lots of great pictures. It will discuss what needs to be done, including making sure that the pressure is not very high, that there's no ciliary body invasion, and that there's no anterior invasion before you put a needle in anteriorly. Brachytherapy is still also used for retinoblastoma. That's correct. And for localized seeds, like a group C tumor, it can be very effective. There are some questions about, can we detect chromosomal alterations or predict the possibility of occurrence during the eye during checkups? And absolutely. So when I showed that example, monitoring tumor fraction and monitoring those chromosomal alterations, that's exactly what that's for. So, it's hard for us often to know when to start injecting, when to stop injecting, when the eye is completely clear of disease. And so, what we see visually helps us, but is not the only thing. And sometimes we're wrong, right? Sometimes we think these seeds are clear, and then 2 months later they come back. We were wrong. Or sometimes we think, oh man, next time I see this patient, I'm really going to have to start injecting this eye. And then they come back after another cycle of chemotherapy and they look great. So we don't always know, but using the aqueous humor can help us. It's a what we call companion diagnostic or additional molecular test in addition to what we just see. And let's see. Last couple of questions here are, can we only do fundoscopy of siblings for screening RB? Yeah, I mean, if you're screening siblings for retinoblastoma, unless they have a known RB1 alteration, I think just looking in the eye is reasonable. Now, if you know they have an RB1 alteration, and if you're in the OR, if you have the OCT available, I think you should use it. We do, and we've detected small tumors that way. If you don't, I think that's okay. And you look in the eye to see if anything is growing. That's very reasonable. Is intrauterine chemotherapy possible for retinoblastoma? That's a great question. I have never heard of that. In some places, they recommend early delivery of the child, but to my knowledge, no one's doing intrauterine chemotherapy. And we have not ever had a need to do intracameral chemotherapy. That's another question. So totally different parts of the body, uterus, intracameral, AC. Of course, that's well described, and that work has been led by Francis Munier. And people around the world now are doing intracameral. Again, for us, it's just not ever been something that we've needed to do if we have disease that's that advanced. Usually we're talking about enucleation. Now, if it's the last remaining eye, that would be an indication to do that. But it's a hard situation when you've got anterior chamber seeds in the last remaining eye. So I have not had the pleasure of doing that, but I love watching the videos. And then I think I've answered all the questions more or less. So the last one that I see here is, are you going to do an aqueous tap for every child with coats or only those eyes with total RD? I think that depends on how clear you feel clinically. Because we have this clinical test, I didn't present this data, but this will be published soon. We and our collaborating partners have done over 1,000 paracentesis procedures. And of those, there was one patient who developed a small self-limiting subconj hemorrhage. There have been no significant complications from the procedure in the eye. And so the risk is 1 in 1,000 that you're going to have anything at all. And so far, 0 that thing will be serious. So because it's relatively safe, because these children are already under EUA, it makes it an easy enough thing to do. And then our retina surgeons feel really good taking over the care of the patient. And the parents really love getting a piece of paper that says tumor DNA not found, right? We didn't find evidence of retinoblastoma. Conversely, our patients with retinoblastoma, we have patients who were diagnosed first as Coates or diagnosed as something else, told all sorts of things, told they have congenital glaucoma. And so when they come to us, and we can actually also give them a piece of paper that says DNA found in the aqueous consistent with retinoblastoma, that provides a lot of comfort to them, and I think builds a lot of trust with the team as we proceed to treat their child for tumor in one or both eyes.